We're joined in this interview for RBM Online by Dr. Baris Ata. He's from the Koç University School of Medicine in Istanbul. And we're going to be talking about progestin-primed ovarian stimulation. It's become known as PPOS. And in a new review, it's published in the February issue of the journal, Dr. Ata, he's talked about this stimulation program as increasingly used in ART. So it is relatively new. I think some of the first studies go back quite a few years, but in terms of popularity, I think it's increasingly used. But I want to, first of all, before we talk about progestogens in ovarian stimulation, I want to ask about indications, because this is quite clearly not a protocol that's going to suit every ART patient. So, Dr. Ata, could you first of all clarify which patient groups are most suited to this approach?
Okay. Well, hi, Simon. First of all, thank you for the invitation. And yeah, as the protocol involved progesterone exposure in the follicular phase, or let's say during the stimulation, it would have an effect on endometrium. Endometrium would start secretory transformation much earlier than the trigger, and the embryo, by the time the embryo is ready, the endometrium wouldn't be receptive. So this is not for cycles where there's an intention for a fresh embryo transfer in the same cycle with egg collection. But if there's no intent for a fresh embryo transfer, I mean, like, be it oocyte freezing cycles, be it embryo freezing cycles, like total cryopreservation cycles, it seems to be usable.
And of course, historically, we're familiar with progestogens for suppressing pituitary activity in contraception. But here we are, we're using it now in stimulation. Can you just very briefly explain the endocrinology whereby a progestogen would appear to suppress pituitary activity in the same way as a GnRH analog?
Yeah, I mean, endocrinology is amazing, isn't it? I mean, you can use progestins for contraception, you can use progestins for stimulation, you can use progesterone for triggering ovulation in a stimulation cycle even. Right? So like, it's really depends on time, depends on the doses. But let me briefly review how it achieves pituitary suppression to prevent premature late surgeries and premature ovulation. So both the two GnRH analog, the antagonistic and the agonistic analog, they work through different mechanisms. Like the agonists take time until they achieve down regulation of the receptors on the pituitary, and that's how they render pituitary unresponsive to further GnRH stimulation. Okay? Whereas the antagonistic analog, they competitively inhibit the receptor, and by binding the receptor, they inactivate it. Okay? So different mechanisms in deactivating the pituitary. So what progesterone and what progestins do, they act at one higher level, at the hypothalamic level. What they do is, inspired same in the luteal phase, they slow down the GnRH pulse generator. They don't act on GnRH receptor on the pituitary. They act on the hypothalamic level. They slow down the GnRH pulse generator. And when the frequency of GnRH pulses decreases, the secretion of LH decreases in favor of FSH secretion. That's how progestins prevent premature ovulation during stimulation.
So what you're saying is that in an ovarian stimulation protocol, you can use a progestogen as an alternative to a GnRH agonist or antagonist, in association, of course, with FSH.
Exactly. I mean, if you ask me, the only drug that you can't, or the only medication you can't give up is the gonadotropin for stimulation.
Exactly.
But except for that, I mean, you have, like now even more options now. The agonist, the antagonist, the progestin, and even in some cycles, even if you didn't use anything, they wouldn't necessarily ovulate.
Yeah, and but this is the reason, of course, why it must be used in cycles which are planned for frozen embryo transfer.
Exactly.
So we're talking about freeze-all, PGTA, maybe some examples of embryo donation, egg donation, where the eggs will be banked.
I observe actually the uptake in oocyte donation programs is faster than own oocyte freezers or like total cryo or freeze-all cycles. It's a subjective opinion by my conversations with people during the meetings, congresses, or looking at the papers. I understand the uptake is much faster in oocyte donation cycles.
Okay,
stimulation of oocyte donors.
Yeah. And what about the advantages of using a progestogen over a GnRH analog? I mean, when the antagonists were introduced, they offered patients a much shorter stimulation program, but they are expensive. So if in these freeze embryo cycles we use a progestogen, what will be the advantages to the patient, to the clinic?
Right, so first of all, assuming, as the available data suggests, they are similarly effective and they provide you a similar number of oocytes with similar competence, the progestins are orally used or vaginally. So you save a few injections, depending on your alternative or depending on your comparator protocol. Secondly, they are way more, I mean, they're like, much less, I wouldn't call it inexpensive even. I mean, they're like almost costless. Okay. So I just checked earlier today to see how much does one tablet of 10 milligrams MPA, like medroxyprogesterone acetate, cost in London. It's like one pound, right? So if you use it in the conventional PPOS for 10 pounds, you can achieve pituitary suppression. If you use it in the shorter protocol, like the flexible or however we call it, I mean, if you end up using 5, you can achieve pituitary suppression with 5 pounds. Okay, and similar price for micronized progesterone, whereas the other alternatives like the GnRH antagonist injections are like 40-45 pounds a day. So it really saves money for the patient, and it saves a few injections. And for the clinic, I mean, depends on how we define being like patient friendly. I mean, if it costs less for the patient, it hurts the patient less, and if it makes the treatment more accessible to people, I think it is. We can say it's a more patient-friendly protocol if you do not have an intention to do a fresh transfer in the cycle. Because this cost advantage, I want to highlight one thing. If a fresh transfer would be an option, and if someone would think about switching to a PPOS just to save money, like to decrease the cost, it may not be the case, because for feeding a fresh transfer, even if freezing one more embryo is not an additional cost, for the first transfer, the patient would need to undertake the cost of thawing, the cost of monitoring the first frozen embryo transfer cycle, and the associated indirect cost. So I don't think it would be, like less costly in that scenario. So I wouldn't recommend it. But if there's no intention for a fresh transfer anyways, it's obviously,
exactly. I mean, I wouldn't think your scenario is likely to happen, is it? I can't imagine that this protocol will be applied in a fresh transfer cycle.
I mean, it wouldn't make sense if there is the intention.
Yeah. Okay, I understand that. So what you're saying is the advantages mainly lie with the patient in terms of cost, convenience, and I'm sure most would prefer a tablet to an injection. So I mean, I think these are quite important advantages. But I want to pick up a point that you made, and these advantages can only be appreciated, I think, if the outcome from this PPOS approach is the same as we'd find from an antagonist. And can we be sure of that? I mean, you talked about the number of oocytes collected and other markers of efficacy. I mean, are you convinced that the outcomes are the same, that the effect is comparable with an antagonist?
Yeah, so let me, kind of recap that historically in a way. So the first report was, as you said, it's not that old. I mean, the first report was 2014 by Dr. Huang from China.
Yes.
And initially, all the studies were retrospective, came from one country. Okay, and science is about reproducibility, right? I mean, people should have similar observations under different settings, and preferably by different people. So over the years, the studies kind of mushroomed, so to say. And now there are studies from different countries in Europe, I mean different parts of the world, in addition to the original initial Chinese studies. Though they are mostly retrospective or non-randomized, there are a few good quality randomized studies. Let's say, Juan Gil from EVRMA in Spain, they published a large RCT on oocyte donors, comparing
Yes.
PPOS with the
Yes.
antagonist. There was another Spanish study from Barcelona. The first order was Beguera. Again, they compared oocyte donors, two different cycles. PPOS versus antagonist. What I would say, the consistency in results are striking. Okay, because normally when you take different samples, you would expect a spread, right, around the real effect. So here, almost invariably, almost all the studies suggest similar oocyte yield, similar maturation rate, and when it's reported, similar laboratory performance in terms of fertilization and embryo development. Okay?
Yeah.
So this consistency, if we take, say, the grade approach, like consistent observations from different groups over time, increases your confidence in the estimate. So personally, I think there are really, many studies now, and I personally do not expect the results to change with additional studies, but like proper bigger RCTs are always appreciated.
Yes. I mean, you're in a good position to say this, of course, because you were the author of a systematic review of these studies a year or so ago. So I guess you've got a good, clear eye on the outcomes of these studies. But what about other less obvious things, sort of after fertilization, euploidy or blastulation, these things, are they comparable as well with GnRH analogues?
Thank you for bringing this up. So we devoted a section on this in the review, particularly.
Yes.
Again, so the studies looking at euploidy rates are huge. Okay? But however, when you combine them, there are like almost 900 PPOS cycles that underwent PGTA, and like more than 2,000, I think like close to 3,000 antagonist cycles in the overall data. Except for two studies, okay, and again, including a Spanish RCT. No, it's not RCT though, but it's the donors. So are consistently showing similar euploidy rate. Okay. The controversy around euploidy rates, as far as I see, stems from two studies. One of them, we wrote this in detail in the review, is only in a subgroup analysis, which is by definition arbitrary division based on age, and only on a sample of, I think, 19 cycles. Okay, so the euploidy rate looks lower. And in that study, the overall euploidy rate is so low. And in the particular PPOS arm, it's just like as low as 8%, so which is not consistent with the other studies on the subject. And it's not consistent with the rest of the PGTA literature. Okay. Right? So that makes you question, with all due respect, the performance of the PGTA program. Okay, that's one. And the second study seems to be a duplicate publication, unfortunately, which has some other trouble, which we again explained in the paper. Except for that, like the rest, the majority are consistently showing similar euploidy rates. And I'm also aware of another paper, so I think I can say it now because it's accepted already, and I wrote a commentary on it for another journal. It's coming from Nikos Polizos' team in Barcelona, where they compared two separate cycles two different cycles of the same oocyte donor, one with PPOS, one with antagonist, again reporting similar euploidy rates almost to the decimal. And so I think these are pretty ensuring. And to expand on it, we should be able to think of a biological mechanism, like as to how PPOS would affect oocyte developmental potential.
Right,
so
yeah.
we're giving a small systemic dose of progestin to act on the hypothalamus. Right?
Yes.
So there's a very nice Danish study published in actually 1980s where they compared, where they reported steroid levels in follicular fluid across the menstrual cycle. Early follicular phase, late follicular phase, early luteal phase, late luteal phase. The follicular fluid progesterone concentration, even in the follicular phase, is so high, like the median values were like 72 nanograms per milliliter. Right? So the oocyte seems to be swimming in progesterone in the follicular phase anyways. And I personally do not expect a small dose of like systemic progesterone would make a significant change in follicular fluid progesterone concentration. But as always, more studies are appreciated.
Yeah, and you can still be confident whichever type of progestin is used. I mean, we know that some are more androgenic than others. I've just seen a study in fertility and sterility with MPA, which seems to be quite commonly used. I mean, that's an oral form. You've also mentioned that there's a vaginal route as well. But from what you can gather from the results, it doesn't really matter which progestogen is used.
Available studies, like there are a few studies comparing different progestins with each other.
Yeah.
They always report similar results. Okay.
Yeah, exactly.
And the studies comparing progestins with agonist or antagonist have used a variety. And I think actually we can say almost every available progestin in the market has been used. I mean, micronized progesterone has been used, MPA has been used, desogestrel has been used, Dianogest has been used. They've all been used, and they all seem to function as long as they act on the hypothalamus. It seems to prevent premature late surge. But I like to really highlight the fact that there are no dose-finding studies like similar to many medications we're using in the IVF setting. So we don't know what is the minimum required dose. The dosages are usually selected arbitrarily. And if I would make one choice, like I think they're all similarly effective. That's what the data shows. But if anyone has a concern about like synthetic progestin, micronized progesterone just works as well.
Yes, yeah. Well, my last question now coming up, and thanks very much for what you said. You said in your latest paper on a shorter protocol that this PPOS approach is being more and more used. And I wonder if you've got any idea to what extent it is being used. In the USA, for example, where I think now about 80% of all cycles are frozen embryo transfers, either freeze-all or for other reasons, PGTA. So I would imagine it's used a great deal in the USA. But have you got any idea of how prevalent an approach it is?
Obviously, we don't have official figures, but you really ask great questions. So I was listening to the fertility on air, at the gym recently. And when they cover like the current one's articles in the sister journal, there was a paper from Brazil which looked at embryo morphokinetics between PPOS and antagonist. So the host, when they were discussing, I realized actually none of the host of the podcast was using it. They were like asking each other. So it's not criticism, that's just a statement of the fact. So we can't criticize anyone for being, cautious. We're in medicine, okay? And it's fine to questioning, but I think we're going through the same curve with what happened with antagonists, right? So you would remember when they first came to the market, the initial data that was published with antagonists was less favorable than this. I mean, like it's
Yes.
the earlier studies, the earlier meta-analysis suggested clinical pregnancy rates were lower with antagonists, which was probably because of either a learning curve or choosing, worse prognosis patients, and it took time to take off, and it was more expensive than the agonist. So here, as I travel for conferences, like frequently invited to talk about PPOS, and the questions I get from the audience, I find it to be used or tried less than I would have expected. I've been using it for four years now, probably more than 4 years now. But I hear from people like, okay, so I just started using it like 2 months ago, 3 months ago after reading these papers, these studies, etc. So I think it's increasing, but it's still minority, and I think it's really didn't take off much in the US, at least for now.
Okay. I mean, I guess most centers are going to be confident in their use of an antagonist now, and I guess they're quite reluctant to change until they're absolutely convinced about the data. But anyway, you've certainly been very reassuring in what you said, and on behalf of RBMO, we're very grateful for your time and interest. So thanks very much.
Oh, I thank you very much. It was such a pleasure.
Good. Thank you.